So my motivation for this project comes from a long-standing interest, as Carol mentioned very nicely, some of my background. So I have a long-standing interest in better understanding the gendered aspects of the political economy of conflict-affected countries. And this spans many topics and is very broad. But the current Ebola outbreak felt like an opportunity to actually engage with some of these issues and look at some country-specific dynamics of what's going on the ground to better understand one of the most major epidemics that's been causing widespread havoc mostly in three countries in West Africa. This picture is so one thing I do as an economist, or I try to do as an economist, is I always try to remember that people are actually why I am doing this, and people's personal stories are really important. It's important, I feel, to bring the personal back in. As economists, we often work with these huge data sets, or we're doing theoretical work, and so we take out history, we take out people. But as social scientists, we need to move them back in. So throughout this talk, I have another number of pictures, which I try and bring the personal back in. This is actually a picture of a man called Joseph Gembo at a cemetery for Ebola victims in Foya, Liberia. Now, Foya is an area in sort of slightly northeastern Liberia, which was sort of the epicenter of their civil war. And so it's been one of the flashpoints for Ebola, and this is a cemetery here. This picture I found very moving for a number of reasons, but Joseph has 4 family members, including his mother buried here, and his family lost 17 family members so far in the Ebola epidemic, spanning both Sierra Leone and Liberia, because he has family in both places. So in watching the current Ebola outbreak unfold from afar, I sort of felt as if I was seeing the impacts on the ground of things that we've been talking about, we've had workshops on, and I especially felt like I could really, in this research project, could bring together some of the connections between gender, public finance, and peace building that I've been working on for a while. And what's been really clear in the current Ebola outbreak in West Africa has been that both of the post-war countries affected, Liberia and Sierra Leone, have lacked both resiliency and state capacity to manage a major health epidemic, and high levels of distrust and lack of legitimacy of the state has impeded the response of dealing with it. So why am I standing here as an economist trying to talk to you about the political economy of post-war peace building being really important when the current Ebola outbreak is something that epidemiologists, people in the medical profession should be talking about? Well, they have a lot of important insights and understandings of it, but I think, well, and the purpose of this talk will be to trace out some of the importance of using a gendered analysis in understanding post-war economies for both Liberia and Sierra Leone. And I think the other thing that it points to is also that gender inequities, paying attention to gender inequities isn't just important because of the equity aspects, but it bears huge economic costs. And the way in which post-war peace building and the economic policies behind post-war peace building with the international community goes on with a lot of gender blind programming bears huge economic costs, and I feel like the current Ebola outbreak is actually a place where we're seeing this on the ground. Now, before I get into some of that, let me just give a brief sort of overview of Ebola. It's now referred to as the Ebola virus disease, EVD. It's a severe, often fatal illness in humans. It first appeared in 1976 in 2 simultaneous outbreaks, one in Nzara, Sudan, and the other in Yambuku in the DRC. The latter occurred in a village near the Ebola River, and this is a picture of the Ebola River from which the disease takes the name. There's been, so in doing this, or putting together this talk, I was able to look back through some of the epidemiological literature on Ebola, which I found really fascinating. But that's not the point of my talk. But I think a few things, I wanted to start with this, is it gives us a little entry point into looking at it. And so one of the things to know about Ebola is that there's been over 22 major outbreaks documented since 1976, and they haven't followed similar, each outbreak has followed slightly different pattern. All of them have been much, much smaller in the scale and severity than the current Ebola outbreak. Death rates have ranged from around 25% in Uganda in 2007 to 89% in the Republic of Congo in an outbreak in 2002. Now it's thought that most people know by now that in terms of transmission, it's thought that fruit bats are the sort of natural hosts for the Ebola virus. They think that it's introduced into human populations through the consumption of infected animals, not just fruit bats, chimpanzees, gorillas, porcupines, most of whom they think are ill or dead, that are then consumed by humans. It then spreads human-to-human transmission through direct contact, through broken skin, mucous membranes, or other bodily fluids of infected people. But the other component of Ebola is that it also spreads by surfaces and materials, bedding, clothing, contaminated with the fluids of people infected with Ebola. So it's a highly contagious disease. In previous outbreaks, healthcare workers were seen to have much higher infection rates than other populations. So what does Ebola have to do with sex and gender? Previous outbreaks of Ebola have shown huge variability in terms of gender outcomes. We only have 11 outbreaks where we have gender disaggregated statistics, and of those, only about 5 show greater female infection rates. So my contention at this point is that taking into account sex and gender differences will really matter and have important sort of ramifications in understanding how we think about building more resilient communities, but also how we think about a healthcare sector that is resilient to, or has the ability to deal with major diseases. So I have 2 slides, so I'm trying not to be an economist too much in this talk, but I do have a little bit of data to talk about, and here is a couple of graphs I have. So I was really interested in the sex disaggregated data on Ebola, which for the current outbreak we'll get to, but we have much better understanding and collection of sex disaggregated data from prior outbreaks, partly because they were much smaller and much more contained. But I want to show you the difference between, in this sex disaggregated data, to make the point that understanding the disease trajectory, transmission mechanisms, how we would think about responses, varies by the transmission rates between genders. Here's a graph of the Uganda outbreak where we have data, and as you can see, it looks like a normal distribution. Yes, people who have had to suffer through stats. Yes, slight right tail. But you see that overall, throughout this entire outbreak, there are higher infection rates of women. And I think it was around, at the end of this outbreak, it was around 63% of cases were female. Now this case can be contrasted to an outbreak in the DRC in 2001, where there's initially higher female infection rates, but after a couple of weeks, higher male until about, I think this is about week 10. And in this pattern, total female cases were about 50%. But I think this is a really good visualization because it shows us that if we if we were thinking about trying to have interventions on the ground, thinking about community-based responses to Ebola, it would vary depending upon whether we had this understanding of transmission rates by gender or this. And so there's a time component to Ebola that I think is really important for us to take into account. Now let us get to the current outbreak. So here is data on the current Ebola outbreak. For those of you suffering through all my data labs in my current classes, this is our WHO data. And this is the most widely used and referenced data on the current Ebola outbreak. This is data that's updated till about the 8th of February. There is a slightly more updated data, but I'd updated this talk too many times, so you get 2-week-old data. As you can see, there's just under 23,000 cases of Ebola that have been documented, and of those, just over 9,000 of which people have died. So as it currently stands, the death rate is around 40%. Now, when I had agreed to give this talk and was researching about Ebola in the fall, death rates were much higher. So they were around 70%. And the anecdotal evidence, things coming out of the Ministry of Health from the Liberia, et cetera, were saying that there was much higher infection and death rates of women in this outbreak. Okay, so what does the data show, the gender disaggregated data? Well, I do have some gender disaggregated data, again from the WHO for February 11th. And here it's given in terms of per 100,000 of the population. This really matters in war-affected countries where you'll have you could have large segments of the male population dead, so you want to know infection and death rates relative to the total population for female or male. So you can see that it's around. It looks like it's around 50. It's very similar for female and male infection rates in Liberia, much higher in Sierra Leone, slightly higher in Guinea. Okay, but one thing that's really striking about this data is how different it is to the data that was coming out in the fall. So in October, there was one instance of gender disaggregated data on Ebola from these 3 countries. And at that point, there was about 8,000 cases of Ebola. We had gender disaggregated statistics for just over 700 of them. And female rates of infection were significantly higher, though there was variability between the countries. But there was, but this was sort of like a data black hole. We had 8,000 cases that we knew of, and we only had 700 cases of gender disaggregated statistics. So do you trust that data? Well, does it tell you anything? Well, it would be data that you'd be really tentative about drawing firm conclusions from. So this, what's interesting to me is how many cases since then they feel they can identify by gender, and I'm just very cautious of our gender disaggregated statistics at this point. One thing being, they've gone back to data they had and assigned gender, and I'm just not sure how they have done that. And so it is, so I like to use data, but I like to be a data skeptic, as all my students know. So I felt like in the fall, I was around a lot of people who were talking about and mentioning how it was just so sad there wasn't really good political economy analysis of this current Ebola outbreak. And as I listened to these mostly male economists talk about this deficit, I felt like this was a time that I could actually start working on something, and very nicely start working with a couple of students on a topic and talk about gender and peace building. So at this point, what does the data not show? I'm not sure we can trust the data. I'm not sure it tells us very much. And this brings us back to the title of the talk, which was meant to be a little provocative, but it was also meant to sort of accurately reflect the seriousness of taking both sex, gender, and economics into consideration in better understanding an epidemic-prone infectious disease. And so when I agreed to give this talk in the fall, I just given, in my economic development course, I just spent a couple of classes walking my students through how I would do a political economy analysis of the current Ebola outbreak. And that's sort of what this talk has turned into. Thank you, students from the fall, one of whom is here today. And so this argument really has three elements to it. Why are women on the front line in this disease? Well, first, it's really a biological argument based on the epidemiological literature. The thought is, or the feeling is, that pregnant women will have a much higher susceptibility to Ebola. And it's not, they don't think it's actually through transmission, through, where do they think it's from? They think pregnant women are much more susceptible to Ebola because of a higher contact with healthcare centers. So in the pre and postnatal care, it's their contact with healthcare workers who have higher infection rates, and with Ebola spreading in healthcare centers so rapidly. So this is sort of an interesting twist on the biological argument. What was also really interesting in the epidemiological literature on this is that there's, in terms of evidence, there's actually conflicting evidence whether case fatality rates are higher in pregnant women or not. You would think that they actually would be because of the way Ebola works, and that it's a disease that makes you bleed internally. But in the prior Ebola outbreaks where it's known that this is, it's not actually, well, as I said, there's conflicting evidence. What is really clear with Ebola is that it has disastrous consequences on the developing fetus. So if you are pregnant, your chances of miscarrying are very high. And there's also, connected to this, there's postnatal women who are breastfeeding have very high transmission rates to children who are being breastfed. Okay, so this is sort of the minor biological argument of my three-pronged argument. The second component, and this is what I quizzed my students on, was to say, well, who takes care of the sick? And if we think about labor markets and we think about paid labor, who would this be? Well, this would be who takes care of the sick in the formal healthcare sector. It would be healthcare professionals. And who are they? Well, mostly they are doctors or nurses or midwives. And women make up the large proportion of formal healthcare sector workers in both of these countries. And here's some data from the WHO. From Liberia, it's from 2008, and from Sierra Leone, it's from, I think, 2010. And these are given in the standard way that they look at doctors and nurses for a country. They compare it to the regional average. As you can see, both Liberia and Sierra Leone have much lower levels of doctors and nurses and midwives compared to the regional countries that they're in. While these numbers are interesting, 0.1 0.1 doctor in Liberia per 10,000 of the population. I can't really think of 0.1 of a doctor in my head. But what does this work out to? Well, this worked out in 2008. Guess how many doctors there were in Liberia? Come on, you're in my class. 300?
In Liberia, doctors, let's say 100.
100? Oh, you guys are just too high. 57.
57?
In 2008, there were 57 doctors in the entire country. Now, Liberia is a small country. You'd want to know the population size to know the number of doctors. Its population is, what, just over 4 million? Sierra Leone is around just over 6 million. How many doctors do you think? 70? Oh, now you lowballed. 1,017. In terms of Liberia, there were 978 nurses. For Sierra Leone, there were, sorry, did I just say there was 1,000 doctors? Sorry, there's 136 doctors in Sierra Leone. In terms of nurses, there was just over 1,000, 1,017. What's really interesting, knowing the colonial history of these two places, in terms of Sierra Leone, more than 10% of the nursing stock of their country works outside of their country in the UK. So there are a lot more nurses and midwives that could be working there than are. So these graphs were just very stark indicators to me of how in the both of these countries have experienced rather, well, some people would say large, moderate inflows of overseas development assistance. There's been massive peace building, cooperation frameworks from the international community, detailing the way in which post-war reconstruction is going to go on, covering governance, economic, social, health, human rights issues. And this is what we got. In the healthcare sector, we got 57 doctors in Liberia, and in Sierra Leone, 136. So it's just, for me, sort of the use of this data is just a very visual representation of how, in terms of healthcare, we did not rebuild a resilient public healthcare sector and without having trained personnel on the ground. I'm not sure how you effectively deal with a major infectious disease wiping through your country. So the first question was to say, who cares for the sick? To look at it, we can look at the paid labor market in terms of the healthcare sector. And then, let me end on this. This is a picture, bringing back in the people, right? So this woman, Thelma Kane, she is a healthcare worker in Monrovia in an Ebola infectious ward unit. She used to actually work in the countryside in a hospital that got shut down, and she took a job with an NGO. But there's these wonderful picture series, actually through the Wall Street Journal, of Ebola healthcare workers that have been done. And this set, it's much longer. It framed her getting dressed to go to work, or actually in the hospital, getting dressed to go into the ward. And she has to do this multiple times a day, and it's incredibly elaborate procedure. Okay, so these are our paid healthcare workers. Let's think about unpaid care, unpaid healthcare. Well, who does it? Well, in the majority of places in the world, culturally, women have the responsibility of taking care of sick family members. This picture I used in the fall. My students loved her story. Her name is Fatu Kakula. She's a 22-year-old she lives a couple hours away from Monrovia in Liberia. And she became quite famous because she single-handedly looked after 4 family members who became sick with Ebola. Initially, there was a hospital near her, that she was able to take her father, who was the first member who got infected. But then that hospital closed down. Can anybody guess why? Why might a hospital close?
All the professionals got Ebola.
All the professionals died, yes, all the healthcare workers. So he then had to come back home. She drove him to the capital city. She went to 5 different hospitals to try and admit him. They were all filled to capacity and they wouldn't touch him, so she had to go home. She took him home. Then 3 other family members got sick. But her story is not, it's also a very inspiring story because of how she did it. She's and one of the reasons you know why how she did this was that she's a final year, she's in her 4th year, she's a 4th year nursing student, so she has training, she's actually a medical professional. She isolated every person in her house in separate areas, and she single-handedly took care of them, and she isolated herself in her community. With a cell phone, she talked to a local doctor, and she was able to, that doctor called in medicines when she needed them, or to do oral rehydration when they got really sick. And she also didn't go out, so she quarantined her household. And she had a really high success rate, but not full success rate. She had one person, her young cousin who lived with them, died. But she developed, as she had no access to any of these full TVIC suits, she devised her own method, which again is actually much more elaborate than the picture shows. She would put on trash bags over her socks, then she would put them in Wellington boots, and then she would put a trash bag over those. Then she would step in these buckets of bleach. She was wearing 4 gloves on each hand for her hair. She put it in fishnet tights, and then she put a garbage bag over it, and then she taped it down. And it's not fail-proof. She could have caught Ebola, but she was careful and vigilant, and she used a lot of bleach and buckets with her family member. So her story, I thought, was a nice way of sort of representing unpaid, very gendered responsibilities behind healthcare, taking care of sick family members. And the last thing to think of in terms of gender, in terms of understanding Ebola and transmission mechanisms, is funeral traditions in these areas. It really matters who takes care of the dead. And so funeral traditions in many of these communities dictate that women especially, often the oldest woman, prepares the body for the next life. And another thing to note is that funerals often take not just days, but weeks. The higher, depending upon the status and respect for the person, funerals go on a long time, and they involve extensive cleansing, or can involve extensive cleansing rituals, all of which usually are done by women, some of which involve kissing the body, but often even just washing. And when people have died of Ebola, the body itself is highly, highly infectious. So, and funeral traditions have been these flash infection points for the spread of Ebola. Yes, so okay, so this is a picture of one of these funerals in Freetown, Sierra Leone, so if I was just sort of stopping here in my argument about sex and gender in understanding Ebola, well then I would include Guinea in what I was talking about, and we would say that gender and sex both matter. But that's not where I stop in my argument. I think one of the really important factors to understand this outbreak, and also look at rates being, levels of Ebola infection being much higher in Sierra Leone and Liberia, I feel has to do with recognizing the history of two very conflict-affected countries. So this is where I try and answer, what does war have to do with it? Since the, let me just mention, since the early 1980s for Liberia and the early 1990s for Sierra Leone, both these countries experienced intense periods of sustained political, economic, social disruption. These conflicts involved widespread violations of human rights, killings, disappearances, torture, forced recruitment, widespread gendered violence, sexual violence, use of child soldiers, and forced and displaced and systemic and forced displacement of populations, millions of people displaced, as well as the indiscriminate targeting of civilians. That sounds like war, doesn't it? Okay, so what does war have to do with understanding Ebola? Well, I was being an economist and working with data. Since the beginning of the outbreak, I have been trying to get hold of gender disaggregated statistics. I've also tried to get hold of district level data for looking at both flashpoints, but also where there was higher infection rates of Ebola, because one hypothesis has been that you can map the war and the impact of the war by district. And so it's really interesting. This is data that's now out of date. It's from the end of January, and this was for the first talk that was prepared. But broadly, the patterns are the same. The higher the orange, the higher the number of cases of Ebola. And one of the things that really struck out, well, there's a couple of things that struck out for me when I was looking at this, but one was this region. This is the Lofa region of Liberia, which it was known as the epicenter of the conflict. And this is where there was massive displacement of people. It's also where you have a lot of diamonds. And you have very porous, another note in terms of understanding Ebola is that these borders, while they are separate nation states, they don't come from the populations there have not known these borders since colonialism, and they're very porous. And the way, and people's livelihoods, especially women's livelihoods, depend upon movement over the border, etc. And so there's a long, I think, a very valid sort of livelihoods and female livelihoods. A lot of women involved in mining in this region. And also the trade networks that go on, where people go over the border. So when they've closed the border, it's had huge ramifications. Okay, so one of the interesting things to note about this current outbreak is that there is broadly some really interesting overlap in places where there's been much higher infection rates of Ebola, also were very important regions for during these conflicts. Along with that, large displacements of the population, rapid urbanization that we saw in Monrovia and Freetown, are also the other flashpoints for this disease. And it's not surprising that in the capital cities where you have large slums, you see with low levels of sanitation, etc., you see flashpoints of infectious disease. But it's also where we've seen large, these areas are also where we've seen large, often internal migration from the conflict on. Okay, so, yeah.
So other countries, the data is not available, or did it drop off that sharply?
In terms of
Cote d'Ivoire and Mali.
Oh, well, now they have a few cases, Mali, but yeah, very, very few. Cote d'Ivoire, I think there's a couple. Mali, there's a few, but they really, yeah. So, and yeah, but you know what's really interesting, I mean, Guinea's the really sad story. A whole separate piece needs to be written about Ebola in Guinea, because initially, the epidemic looked like it was actually really contained there. And it's only come back, and it's come back and become much more widespread. You had a lot of districts that didn't have it. And part of they think, or the people writing about it think it has to do a lot with the funeral traditions. So one of the things I think I forgot to mention in the funerals, one reason they go on for not just days, they can go on for weeks, is that to respect the dead and to help them go into the next life, people other family members have to come and pay their respects. And so what does that involve? It involves people coming to a highly infectious body, contracting Ebola, and then taking it back. And so the flashpoints in Guinea seem to be much more about funeral traditions and migration, whereas it seems the patterns are just different with Sierra Leone and Liberia, and we've got it broken down, not gender disaggregated, but we do have it broken down by district over time, so you can see when these flashpoints were arising. Okay, so I know I need to finish up. You guys have been very patient. I'm not really finished with the talk, but let me get to some of the arguments. Okay, so this is where I sort of want to bring in this last angle, which is an angle that I find is often very useful to talk to people in sort of the non-economists who are interested in peace building, because this is one of the ways that we can actually be useful. We can follow the money. So public finance is a large topic, but it essentially covers how you get money and how you spend it. And in between both of those is how you prioritize. What do you prioritize with? A budget. And so it's a deeply political process. Who you get money from, how you put it on paper, you're gonna allocate it, and then how you actually go about allocating resources. But it really matters in peace building. Let me just also say that this work really draws upon a book written by James Boyce and Madeline, what's her name? Madeline O'Donnell, I think her name is. They wrote a book called Peace in the Public Purse, and it was essentially about why public finance is really important in peace building. And I use sort of their framing of the arguments, but I bring in gender, because I think that to understand public finance and peace building and not bring in gender, you're sort of missing a big part of the political economy argument that is really useful. Okay, so a very important component of having an effective state is one with the capacity to mobilize resources, allocate resources, and also manage expenditures. And the argument here is also that state legitimacy rests upon a state being able to provide public goods and services, as well as a willingness to respond to the expressed needs or demands of the population. Now, this is key because of the history of both Sierra Leone and Liberia, where states were not seen and continue often to not be seen as legitimate. And there's a huge amount of evidence now talking about what happened in neighborhoods trying to contain the Ebola outbreak in both of these countries, and they received, and people coming in to quarantine the neighborhoods to give information, etc., were received incredibly hostilely. And in reading these reports, to me it has sort of leapt out this sort of post-war peace building component of these are often populations that are deeply mistrustful of the state. They're also where you have high levels of unemployment, of young youth who were often heavily involved in the conflicts. And they have not seen a state presence in terms of provisioning or providing, yet a major health epidemic sweeps through their country, and then who comes into the neighborhood? Like, there's been a lot of reports written about this slum in Monrovia called West Point, where a lot of IDPs from the conflict came. And West Point is fascinating. It's this little strip of land right on the edge. They think over 70,000 people live there. There's like 4 toilets. So most people defecate out in the open. Not very good for an infectious disease. West Point, they tried to contain Ebola in West Point. And how did they try and do it? Who did they bring in? They brought in the military into these communities that have not seen a legitimate state in terms of provisioning, and no wonder people responded so hostilely. And so there's a lot of examples of this, which we're looking at in terms of where the public were so hostile to any outside help. And some of it was healthcare workers, etc. So, and this is this picture, the last picture I'll use in the talk, is an incredibly depressing. This is an Ebola victim who's quarantined in his home, really outside in a plastic chair with a bucket. So the war and the post-war environment are really important issues that I feel we need to bring gender into the mix, and once we do that, we then need to follow the money. And so this is something that I started a number of years ago, looking at a number of case study countries, Sierra Leone being one, where I went from looking at the planning documents in the international community, that the international community used, these post-conflict needs assessments or common development frameworks, and then essentially looked at where gender and gender equity, gender needs were coming up, and then followed the money through the system down to the project level to see what was getting prioritized. And this again is very public finance-y, because you're looking at what is getting planned, where is money coming from, where is it going. And one of the things that was stood out in this process, and this is includes this is this 5-country case study that's bigger than just Sierra Leone and Liberia, though it does the data is also there for these 2 countries. The thing that was just so fascinating in this process is that most of the money goes to economic recovery and infrastructure, which is really important and needs to be done, and is also part of rebuilding sort of state legitimacy to get roads back up and working, electricity, etc. But where does health come down here? There's just huge inequities in post-war financing, and this is sort of where this project has got to in terms of looking at Sierra Leone and Liberia. We've been going through these planning documents and looking at the attention to the health sector, as well as sort of more broadly gender equity concerns, and it's sort of interesting following the money, but it's also, I think, has a lot of lessons. We have a lot of lessons to learn from this process, because Sierra Leone and Liberia haven't had the worst peace building planning going on. They've had very interesting initiatives going on. There have been funding of programs that really have looked at sort of reconciliation within the communities. But in the large scale scheme of things, there are massive disparities in prioritization and where money is flowing, and that it feels like we can do a better job. So if you're taking a public finance approach to looking at or trying to understand the post-war context of Liberia and Sierra Leone, you have to understand how resources are generated. In the post-war environment, most countries do not generate enough revenue internally Most of this is through tax revenue. You can do it from individuals. You can do it from corporations. Most of it comes externally from the international community in the form of official development assistance. Most people think of official development assistance, I get this from a lot of my students, they think of aid being free money. It's usually not. It's usually concessional. It's usually a loan, but given on concessional rates. So what is Liberia and Sierra Leone, though, are not. They may be income poor countries in terms of the majority of the population are still in the agricultural sector, dependent upon rain-fed agriculture. Poverty rates are very high, but these are not resource poor countries. Both countries have high levels of mineral wealth and resources, and this is a form of internal revenue that I think can actually help peace building if we did it differently. Okay, so this graph was really a way of saying official development assistance is flowing into both of these countries. You can see, especially in the case of Liberia, quite a bit coming in. The question is, where is it gone? Has it just round-tripped back out in terms of capital flight? Or can we look at where there's been sort of sector-based prioritization, and this is where we're starting to look at now documents from the Ministry of Finance and Planning to do that. So I think, I'm really sorry, I've talked and talked and talked. I will stop there. This is the beginning of a research project that I'm really happy to be working on with a couple of former students. I'd be happy to answer any questions. Yes, that's it.
Yeah, good afternoon, everyone. My name is Kade Finnoff, and Econs 418 class student right now. I want to find out if there are a breakthrough as to finding solution in terms of vaccine or medicine to the problem of Ebola, especially as it is ravaging Africa. Thank you.
Do you want to collect a few and then answer, or?
Sure.
Whoever works for you. You're up there. Just...
All right, well, let me respond because I might get scattered, even though I did take a note. So in terms of there isn't a vaccine yet, but there has been a fair amount of work put in to trying to develop a vaccine, and there's a couple that are undergoing human trials right now. There are ways of treating Ebola that seem much more effective than not, especially oral rehydration of patients is very important. But the most effective way of reducing transmission rates really is isolation. But you need people to take care of people who are very sick to do that. So in that case, you need a healthcare sector with capacity. And so, yes, I'm going to stop there.
Good afternoon. Good afternoon. My name is Kojo. Professor Kade, my question is, can you expand a little bit more about the public, the government expenditure on health to the public? Thanks.
So I do have some graphs. I wasn't going to show them. I know, now I do have a good excuse. So, you know, what's really interesting about the public healthcare expenditure, so what's been really interesting has been trying to find out what the government expenditure on health is per person for these countries and whether it's changed over time, because one of the questions is with peace building being funded and healthcare, especially in Liberia's case, it was one of the priority areas was addressing the health needs, especially of internally displaced populations through the conflict. So it's been a little hard to find actually a separation between personal versus public expenditure on healthcare, because in poor countries often, well, Latin America, no exception, you get high levels of personal expenditure on healthcare. And so, but these are, so I have for both Liberia and Sierra Leone, and broadly you see it rising when you're not in conflict. So, so that's Liberia, and then this is Sierra Leone. A little more fluctuation. And one of the things I wasn't able to say in the talk, but I did actually want to say is that Liberia and Sierra Leone, so they're not worst case scenarios of post-war reconstruction. There is some very interesting initiatives that have gone on with it, but I think there's a lot more that can be done, and we can also take a lot of lessons learned from this experience. And in terms of healthcare, healthcare and health needs of the populations was, I think, in a better extent prioritized in Liberia versus Sierra Leone, and donors have been involved in addressing healthcare issues. But what's so interesting about that is that they've been very focused in looking at some of the project documents. They haven't been talking about recreation of public healthcare infrastructure. Initially, just after the conflict, they were talking about sort of rural health clinics, etc. But most of the focus has been on actually addressing health outcome indicators. And so the health outcome indicators that people are very concerned about are levels of immunization for children, also people sleeping under bed nets in terms of malaria, dengue fever, and then maternal mortality rates. Liberia has been actually, both Liberia and Sierra Leone have seen declines in maternal mortality rates, and there's been sort of a heavy push for better outcomes in this area. So that's not to say we shouldn't focus on improving health outcome indicators. It's certainly very important, but actually rebuilding the health infrastructure is an important component of resiliency, and that seems to have been much more missed in this.